We're going to have a lot of people kind of coming in, hopefully some more trickle in soon. But we're really lucky here. I'm one of our IBD providers as well. We're really lucky that we have a great multidisciplinary team. We have a lot of experts because a lot of aspects of GI care and IBD care are pretty complicated. And pregnancy is one of them. And this is a population that, a lot of people are affected by IBD that are. Guys, we're starting. Can you get the doors? Thank you. A lot of people are affected by IBD who are, of childbearing age and want to have children or become pregnant. So it's a really important topic. We're very lucky to have a diverse group of experts here. So we're going to start off with Dr. Siobhan Proksell. And she is one of our gastroenterologists who specializes in IBD and has a particular specialization and expertise in management of IBD during pregnancy. So that's our first talk. So coming up, Siobhan, thank you.
Okay, good morning. So like Dr. Steiner said, I'm going to talk about IBD and pregnancy, but I'm specifically going to try to address it from the GI perspective. And then you'll hear a little bit more about it from the MFM perspective and from a nutrition perspective. These are my disclosures. I will briefly veer off course and talk about contraception for a minute. Then I'll talk a little bit more about inflammatory bowel disease and how the therapies affect fertility. We'll talk a little bit about preconception counseling and some strategies, and then talk about the updated management recommendations that have come out in the past year. So contraception in IBD is a big deal. We would like our patients to have effective contraception. And so this table over here on the right goes from least effective methods at preventing pregnancy to the most effective methods. So barrier methods, things like condoms, obviously, are the least effective. Effective use is paramount here. But realistically, there's no side effects and they can protect against STIs. So there's a benefit there. Then we move on to the oral contraceptive pills. So you have two options here. You have combined oral contraceptives, which are going to contain estrogen and progesterone. And then you have progesterone-only pills. And so with the combined pills, there's a known increased risk of venous thromboembolism in the general population. There's very few studies or essentially no data specifically in IBD patients. And so theoretically, if they're not flaring, that risk isn't increased. But if they have other reasons to have an increased risk, like a prior history of venous thromboembolism, like smoking, like active disease, like use of JAK inhibitors, steroids, recent surgery, then you really want to avoid these. You can avoid it by using a progesterone-only pill, but these are incredibly difficult to take. You have to take them within the same 3-hour window every single day. And I don't know about you guys, but I would not trust myself to do that on a regular basis, day in and day out. So there's room for failure there too. And then the other thing that you really need to think about is in your Crohn's patients. So if you've had Crohn's patients that have had extensive disease, that have had multiple resections and multiple surgeries, they're not going to absorb these as effectively as some of your other patients will. And so that's maybe another reason to avoid using them. And so if you take one thing away from this slide, take away that the long-acting reversible contraception agents are what are preferred in our patients with IBD. They have a very low failure rate, less than 1%. They're great long-term options. Some of them can last up to 10 years. So if your patients are not planning on becoming pregnant within the next year, these are really great options here. They also don't have estrogen in them. And so you're avoiding that increased venous thromboembolism risk. There is a comment here about potential costs and pain associated with insertion. And it used to be that women were referred for IUDs and they didn't get any sort of pain management during them. This has really shifted, I think, more recently, and a lot of the gynecologists are even doing these under propofol sedation. And so hopefully that's going to become more and more normal in providing actual pain control for this. So that was my don't get pregnant talk. Now we'll focus on pregnancy. So to put it in perspective, there's about 3 million people in the country that have inflammatory bowel disease. Half of these are women, and most of these women are getting diagnosed during childbearing years. So this is huge, right? They are getting told that they have this chronic autoimmune inflammatory disease that requires lifelong treatment, which is a big enough deal. And at the same time, this is when they are likely to become pregnant. So what does it mean for fertility for these patients? So if they're in remission and if they have uncomplicated disease, for all intents and purposes, their fertility rates are the same as the general population. It might be slightly lower, but it's pretty on par. Once, though, you start to have complicated surgeries like J pouches, proctectomies, or ostomies, those fertility rates decrease, particularly with J pouches, upwards of 35, even 40%. And with active disease, fertility rates also decrease. But it doesn't mean that they can't get pregnant. And so you absolutely may have somebody get pregnant while they have active disease. It's just not ideal. And then what about referring to REI? So in the general world, if women are actively trying to get pregnant and we'll tell them wait for a year and then we'll refer you. I don't wait that long in IBD patients. They have a complex history. They've had inflammation. They may have had surgeries. And so if they've been actively trying to get pregnant for a few months and they haven't been successful in spite of monitoring their cycles, I'll refer them then, because they're not going to get in tomorrow. These referrals take time, right? And so they're still not going to be seen for a few months. And at that point, if they still haven't got pregnant, you really want to get the ball rolling. I think the other thing to point out is there had been, I think, a lot of questions around egg retrieval and fertility preservation. And there's a lot of data to show that this is safe. It's fine to do in women with IBD, and it does not increase their risk of flaring. And so those are, I think, important from that perspective. From the patient perspective, the voluntary childlessness rates in IBD are significantly higher than the general population. So 18% of women with IBD choose not to get pregnant, not because they can't, or we tell them that it's not safe. They can, they just choose not to, versus 6% of the general population. And a lot of that comes from misinformation. And so there are studies that show that women know that it's important to stay on therapy when they're pregnant, but they think that it actually may cause harm to the baby. And there's also a lot of data to show that if we just talk to them beforehand and explain this, that voluntary childlessness rates decrease significantly. And so just bringing up that, even in passing, can have a huge impact on your patients' lives. So who needs to be involved in the care of your patients during pregnancy? You should, right? You know them well. You know their disease. You know your medications. You need an obstetrician. It could be MFM, which Dr. Johnson is, or it could be obstetrics if they have very uncomplicated disease, general obstetrics. Hopefully they don't need colorectal surgery, but they may, and you need to have someone who's comfortable with that as well. And then you need to consider things like nutrition, which Stacey's going to talk a lot more about, lactation, and then behavioral health support too. All of those things are hugely important. So before pregnancy, I talk to my patients about preconception. I talk to them about what pregnancy means, how we monitor things, what modes of delivery are appropriate for them, and what we would do post-delivery. We talk about fertility rates, which I mentioned. I talk about the importance of being in remission. We briefly touch on nutrition, and then I send them to Stacey so they can have an hour-long talk with her about how important it is. And then we go over their medications well before they're interested in becoming pregnant. And then we talk about infant considerations. I try to give people resources that are not going to send them down the deep black hole of Reddit. And so the IBD Parenthood Project is a really nice resource, Crohn's and colitis. I used to give them the IBD pregnancy clinical care pathway from the AGA, but now we have the updated global consensus. And so that's what I refer them to. So I really like for my patients to be in remission for 3 to 6 months prior to conception. Having them be healthy is the best way to ensure or predict a healthy pregnancy. I'll let Stacey and Dr. Johnson talk a little bit more about nutrition, but I'm going to check basic labs when I see them. So folic acid, iron, vitamin B12, vitamin D, they need to have folic acid supplementation, and this is going to differ based on the severity of their disease, which we'll talk about in the next couple of talks. And then ideally, if they've been severely sick or flaring, you want them to be back to their ideal weight, right? A healthy weight to ensure a healthy pregnancy. So the meat of the talk is going to be about medications, because I think this is what scares everybody in pregnancy and IBD. So if you've seen this before, I use this. I think it's just kind of a helpful, quick guide. I think at this point, we all know mesalamines are safe preconception, during pregnancy, during lactation. And thiopurines are as well. There had been some concern about an increased risk of cholestasis in pregnancy with thiopurines. And so I always make sure I'm checking metabolites and I check LFTs as well. If patients are shunting already towards 6 mmP, you can just split the dose. So instead of giving them their dose just once a day, you can do half in the morning, half in the evening, and then recheck and see how they do. There are some times where we will decrease the dose significantly and add allopurinol. I'll always do this in conjunction with MFM. There's really little data, but if your patient is in deep remission with this medication, to just pull something off is going to make them flare, and that's horrible for them, horrible for pregnancy, horrible for outcomes. Methotrexate is a big no-no. We all know this. A lot of our pediatric patients who are transitioning to adult care are on methotrexate because the options in pediatrics are so limited in comparison to adults. So if I have young women come to me on methotrexate, one of the first things I'll do is get them off of it, not because they have imminent plans to become pregnant, but because I don't want to deal with it when they do want to become pregnant. So I want to know that they're in deep remission well before I need to make any changes, or well before they're even trying to think of conceiving. And pregnancies, unintentional pregnancies happen. And so you just want to take that away if you can. Steroids. You treat a flare if it happens, but I still minimize their use just like you would in management of IBD. You don't use steroids as maintenance therapy. You're not going to use it as maintenance therapy throughout a pregnancy, but you're absolutely going to treat a flare if you need to. Otherwise, the next three are going to be your biologics. So anti-TNFs, which are infliximab, adalimumab, certolizumab, golimumab, your Entyvio, your Vito, your ustekinumab, your risankizumab, your mirikizumab, your guselkumab, all of those are safe. They're big. They're huge. They don't cross the placenta during the first trimester. They do a little bit afterwards, but they do not cause problems in terms of fetal development, in terms of infectious risk. We know that these are safe preconception, throughout pregnancy, and during lactation. And the way that I explain this to patients is the molecule is so big that you can't take a pill for this, right? You have to inject it or you have to get an infusion. You're not able to absorb it through the gut. And so although there is a very small amount excreted in breast milk that the baby's exposed to, they can't absorb it with any efficacy to cause a problem. And so I think just putting that picture out there really helps with all of this. Then we have the small molecules. So that's going to be your tofacitinib, your upadacitinib, your etrasimod, and your ozanimod. And this is where things kind of get a little bit dicey. So I'm going to talk about these in a lot more detail. With the JAK inhibitors, which are going to be your tofacitinib and your upadacitinib, you want to avoid them, particularly in the first trimester. And this is because animal models have shown fetal harm. With tofacitinib, it's really been much higher doses than we give to the general population, than we give to our patients. And although the data is limited, there's one study that showed about 11 maternal exposures, and all of these outcomes were fine and similar to the general population, but nobody's gonna use 11 patients as the data point to say, sure, this is fine and safe in pregnancy. There was a little bit of additional data that showed exposure in 74 pregnancies, again, outcomes similar to the general population, but the duration of exposure was small. And so if you have other options, use other medications. This shouldn't be your go-to in pregnancy. Similarly, with upadacitinib, we prefer other agents. The issue, and what's a little bit more concerning about UPA, is that these fetal anomalies, particularly musculoskeletal and cardiovascular, were shown in doses that we use in our patients. And so it wasn't these doses that were 10, 20, 30 times higher. It's what we use in our own patients in the first trimester. And so really you want to avoid this if at all possible. There's some newer data that came out, and it was a study looking at 124 maternal exposures or 128 maternal exposures to UPA. And if you kind of look at the headline, you see, okay, there was 128 women who took UPA while they were pregnant, and the outcomes were the same as the general population. But then if you look at the details, the average duration of use of UPA during pregnancy was 5.5 weeks. And so if people discontinued their medication at 5.5 weeks gestation, you cannot use that to say what long-term outcomes are going to be, which is why we still say, hey, pull back on this and use something else if you at all can. There was also from the Piano Registry a recent publication of 6 patients, 3 of whom were exposed during pregnancy. 2 of them started it in the 3rd trimester, and I'm much more comfortable doing that. 1 was on it throughout their entire pregnancy, and again, they did well, but these numbers are small. And we have so many other options that if you can use other options, it's better. Then we have the S1P receptor modulators, and the data that we have really comes from ozanimod, and this is because it's used for multiple sclerosis and has been approved for much longer than it's been approved for IBD. And so there's MS trials that showed similar outcomes to the general population, but now there's also been some data, some safety data that's come out. And so there's a nice registry, and it includes about 6,000 patients, 1,200 UC, about 900 Crohn's, 3,000 MS, obviously, because that's going to be your primary population. And then they included another 900 who were just standard patients, not on any therapy. And their outcomes were also the same as the general population. But similarly to the UPA data, if you look at the average duration of use, it's 5 to 6 weeks. And so everybody's stopping these medications when they become pregnant. The spontaneous abortion rate for these medications is the same as the general population. And so they haven't shown that to be increased. And there hasn't been an increased rate of congenital malformations or increased infections. But again, these do cross the placenta during the 1st trimester as opposed to biologics. And so we stick with the big molecules if we can at all. I think the other thing to point out about ozanimod is its half-life is much longer than the other small molecules. And so you need to be off of this therapy for 3 months before trying to conceive versus the other ones, which are a little bit shorter. So we know that the half-life of TOFA and UPA are pretty short, but we still say, hey, stay on contraception for at least a month after you stop therapy before trying to become pregnant. With ozanimod, it's 12 weeks, and with etrasimod, it's 1 to 2 weeks after the last dose. The moral of the story with small molecules is don't use them if you don't have to, and if you feel like you're stuck and you have to, reach out, and we can help guide these patients. One slide about the guys. There is really no data to show that paternal exposure to any of these therapies affects contraception and affects neonatal outcomes. So all of these medications have been shown to be safe in males across the board. The other medicine I'm going to talk about is aspirin. And this is because, we often tell patients, okay, avoid NSAIDs, don't use NSAIDs. We maybe went a little bit overboard on the avoidance, but I think what's really important to note is that we actually recommend it in all of our pregnant patients with IBD. And so there does seem to be higher rates of preeclampsia in our women that are pregnant that have IBD. A lot of the data comes from studies that were done in the Danish population. They have really nice registries. And so there was one of about 600 patients that showed higher rates of severe preeclampsia in IBD patients. And then there was a national registry that actually included 80,000 IBD patients and then 6 million non-IBD patients. And they didn't separate severe preeclampsia and preeclampsia, but in general, the rates were higher in our IBD patients. And data has shown time and time again that aspirin reduces the risk of preeclampsia and that it's safe in IBD. So we tell all of our women that are between 12 and 16 weeks pregnant to start low-dose aspirin, not baby aspirin, low dose. So 2 baby aspirin, 162. And we continue this until at least 36 weeks. And then I let my OB colleagues tell me when they want to stop it. Sometimes they'll continue it, sometimes they'll stop it earlier, but I at least want to make sure that our patients are on it. And so that is my medication spiel. Delivery, I think, is also important. And so I think, we all know that if patients have active perianal disease, having a vaginal delivery is not a great idea. But I think the recommendation that sometimes slides under the radar is if they've ever had a rectovaginal fistula in the past, active or inactive, they should also have a C-section. And so I also will consider it in a J pouch, depending on what the patient's wishes are and what makes the most sense. But really, the absolute contraindications are going to be present or history of a rectovaginal fistula and then active perianal disease. And then what about babies? We used to make things even more difficult for moms than we already did. And so in general, medications are safe. We have this from the Piano Registry. Sulfasalazine is maybe the least preferred mesalamine, but in general, It's fine. We don't use methotrexate. We really don't use small molecules, but in general, medications are safe. And if you have questions, obviously your obstetrician or MFM would be more than happy to work with you too. But I think the other thing that we used to say is no live vaccines within the first 6 months of life if these babies were born to moms on immunosuppressive therapy. And enough people didn't really know about that recommendation and didn't implement that recommendation. And there's now enough data to show that maybe we're being a little overly cautious. And so in the US, we no longer restrict the vaccine schedule of babies born to these moms. And so they can just get all of their vaccines that are within the AAP recommendations. The only caveat is if they, for some reason, give birth in a country where the BCG vaccine is administered, and we still hold that. And so if they're in the US, they can stick on that schedule. If they're somewhere where the baby would be offered the BCG vaccine, that's the only one that we tell them not to. This had caused a lot, I think, of difficulty with some of my patients because they were being told that they were anti-vaxxers, and that's been tough. And now they can just say, okay, go ahead, do whatever needs to be done. We'll stick with the schedule, and they don't have any issues in that regard now. And then disease activity. So fecal calprotectin is great, and that's accurate. We know that CRP rises with pregnancy, so I don't necessarily trend that unless there's something significant going on. You can do endoscopy, it's low risk, but you're only going to do it if it's going to change your management, right? And then if you need imaging, you can do an IUS if you have that capability. You can do an MRI without gadolinium, and that's preferred over a CT scan. And then what if these patients are flaring? So you're going to treat their flare, right? You can basically use anything that you need to, but I don't start thiopurines in pregnancy because of the small risk of pancreatitis. I don't start methotrexate, I think for obvious reasons. JAK inhibitors, I may, depending on the scenario, but in general, avoid small molecules. And then if they have infections or a fistula or pouchitis, use the right course of low-dose antibiotics. Treat these women as you would treat a non-pregnant patient. You don't let them flare just because they're pregnant. And then the other thing that I like to try and do is get patients involved in research. And so there's the Piano Registry, which is essentially where we've gotten the majority of this data. You can just Google it. You can send an email to refer them. They can refer themselves sometimes as well. And then the Wisdom study is a newer study, and this is looking at women who are interested in becoming pregnant in the next 18 months or so. And it's just getting more information because pregnant women are excluded from everything. The second that somebody is pregnant, they get excluded from every single research trial and every single data set that we're doing. And so just to get more information about how to guide these patients is imperative. And so if you have anybody that would be interested in participating in research, I would definitely advocate for that as well. So I think the other things just to think about, and I'll wrap it up, is how will new medications affect fertility? There's so much coming out. We're going to have to keep track of that. And then do we need to start thinking about fertility preservation in some of our patients too? And I think those questions are going to come up more and more. But to end this, knowledge is essential. So giving our knowledge to our patients and learning about how we can support them is incredibly important. Keeping them in remission is key. It's the best chance at giving them a healthy pregnancy. Fertility can be affected by surgery. It can be affected by active disease, but there are ways to help our patients know about the therapy implications, but most of all, know that they can have healthy pregnancies and they can be pregnant. That's all I have for you. If you have any questions, feel free to email me. Thanks.
All right, excellent. Thank you.